Good morning, everyone. Let me welcome you to our monthly live webcast for the peripheral interventions led by Dr. Krishnan. My name is Sada Fahan. I will be today your solo moderator. Let me first give you a couple of updates. We will have our next peripheral live case on July 28th. It's always the fourth Wednesday of the month. And we will have in October 15 and 16 our annual endovascular summit. It will be carried out as a hybrid event. We're gonna precede this event with an endovascular, an endovascular fellows course on Thursday, the 14th of October. We will be very happy if as many as possible of you can join us live or virtual, since this event is going to be hybrid. So today, Dr. Krishnan selected a very challenging case of a patient with CLI. Without further ado, I'm going to introduce you. We're going to go to the cath lab and see Dr. Krishnan.
Okay, well, welcome everybody. We are getting things ready as we go forward. This is an incredibly challenging case of a patient with critical limb ischemia, and Dr. Avadani is going to go ahead and present the case. Shreya, can you please present the case?
Yes.
Okay, let's do on heparin, guys.
Good morning, everybody.
We get a pressure.
So the patient we have here is a 58-year-old male with a history of peripheral arterial disease. He had prior interventions in the past. He was referred to our clinic for a second opinion for these non-healing arterial ulcers involving his great toe and the third toe of his left foot. He also has severe ischemic rest pain and dependent rubor. His Wi-Fi classification W2, I3, FI1. All of this has been going on over the past 2 months. His exam was notable for dry gangrene and eschar over the medial aspect of the hallux and also the third toe. Of note, he had severe pain even on palpation. Pulse is non-palpable, but present on Doppler. He had popliteal and monophasic DPPT signal. Other medical history, he does have a history of coronary artery disease, and he also had PCI of the LAD to the left main, previously refused surgical intervention back in 2016. He also has CKD stage 3 with a baseline creatinine of 1.6 to 1.8, type 2 diabetes, hypertension, and hyperlipidemia as well. These are his medications. Pertinland labs, his creatinine was 1.75, 1.8 today, and his ABIs, as you can see, calcified on the right, 1.4 with a TBI of 0.3, and on the left side it was a 0.34 with flat PVRs. His arterial duplex was concerning for iliac disease and also CFA disease on the left. These are his diagnostic angiogram images. Can you play the first one? His iliac angiogram was notable for proximal, very calcified, common iliac stenosis on the left side, and I don't know if you can see it, but also involving the left common femoral artery. Can you play the next one? Yep, that calcified nodule in the proximal CFA with occluded SFA distally and very calcified vessels even below the knee. And the right side, that was the diagnostic image.
Can you show the main screen, guys? So basically, this is a very, very challenging case, and I just want to talk about some of the challenges that we have. As you can see, the access it was very difficult on the right side, and then we did an injection. So the profunda is lost. The SFA fills the right side, but the real painful ulcer is on the left. So we got with great difficulty we get up and over, and I want you to see the level of the calcification here. And we're complicated because we have a tortuosity in the right common iliac. We have not an osteal, but a close to osteal left common iliac lesion, which may be the saving grace of what we're going to do. And then you also have the left common femoral is severely calcified. Next. So you can see here as we try to cross, we had a great deal of difficulty, and you can see the eccentric nature of our wire going down, suggesting that this calcification is quite significant for us in terms of how much it is. Did we give heparin, guys? Okay.
We give 2,000.
Did we give heparin?
We give 2,500 through the radio.
Okay, you need to give another 3. Yeah. Okay, so with great difficulty, we're able to get this down, and now we take a picture, and you can see the calcification of the common femoral, distal, and proximal. So the idea here is, well, how are we going to be able to fix this in order to be able to get the patient enough blood flow to be able to do it? So we decided to go ahead and get left radial access next. And you can see here with great difficulty, we get a left radial access. We get our Terumo Navicross catheter down with a supercore wire next.
That's all we are.
And then we went ahead and tracked our R2P sheath all the way down. So now we gave our blood pressure. If you can show the monitor, please. Our blood pressure in the common femoral on the left side is around 100 and 200 in the aorta. 100 millimeter gradient, and remember, we haven't even crossed into the distal, what is it called, SFA, to see what the pressure is on the SFA. Can you show my pressure monitor, please, to our wonderful AV team? So now the issue is how are we going to fix this? So one of the questions is why not surgery? Well, he has a left main stent. And he's got ischemic cardiomyopathy. So therefore, he was turned down for surgery in the outside hospital. So this becomes a really, really challenging case because you need to think about what your bailouts are going to be. So we have contralateral, we have a 5 French access on the contralateral side. And now our plan is going to be able to go ahead with an ipsilateral superficial femoral artery stick. Now, some of the things that we have prepared, I've asked the team to get together our aortic occlusion balloon. I've asked the team to get together a Lunderquist wire, 11 French sheath. I've also asked the team to get together our Metacross balloons to be able to control the superficial femoral artery once we get the actual procedure to be done. So that's kind of the idea. So any thoughts, Vishal? I mean, in terms of what else we can do?
I guess you rightly explained. I mean, the biggest crux of this case is essentially the planning. What's the approach? How do you plan it? Especially with the 2 iliac disease, that's most of the people would do it. But the biggest limiting factor for us is the access on the other side. So now we're looking for alternate access, like you said, getting an SFA access versus a radial access, and then we have to strategize how to fix one, which will go first. Would the SFA go first? You want to get an access there, iliac, and what happens if there's a complication? How to safeguard your common femoral SFA and the iliac thing. So I think this is how we thought about it and we discussed about it, and it's perfectly agreeable to have a radial access, one for visualization, other is control, like you rightly said, in case, and one hopefully use it as a primary access strategy to treat the left side of the system. Because it's so hard, especially with the tortuosity, it's so hard to go up and over and try to fix the left first, and on our way back, fix the right.
Well, you know, the issue here is I want to tell the audience, I mean, we've never aborted a procedure, but this is one I may, depending on how things go, because, you know, I don't really have a lot of bailouts here if you look at it and you analyze this case really, really well. But I think what we're going to do is we gave heparin, we're going to check an ACT. You can see I have a wire up and over, right, from the contralateral side, and it's at the level of the femoral artery. So now I'm just going to go ahead and give a little dye from the R2P sheath to see whether we can get an access here, and then we take it from there. You know, so the idea will be at this stage keep an ACT around 230, 240. Do it on heparin. As you know, we do most of our cases on Angiomax, but in this particular case, we'll see what it is. Okay, ready?
Yeah.
So I just want to see where we're going to get access, and then take it from there. Oh, obviously that's all saline. Let's try again. Okay, wonderful.
Yeah.
So now I'm going to ask Shreya to make this a roadmap.
Yep.
And then what I'm going to do is just try to cross this with my supercore. So.
Micro catheter.
Nah, it's too gritty.
Yeah.
It's way too gritty to be able to cross it. Okay, so what we're going to do is we're just going to get access below. So I need to get enough space to be able to get lower and then be able to get access here.
So obviously, Dr. Krishnan, this is a very challenging case. Any tips and tricks for the audience how to obtain proximal SFA access for such an intervention? Which sheaths, wires?
What we're going to do is we're just going to go. We're going to give a lot of numbing medicine, and then we're going to start. Make sure he has the Metacross balloons. What size does he have? He has a 7.0, I hope.
6.0 and 7.0 we have.
So what we're going to do is we're going to give some numbing medicine into the thigh. So what I do, Sardar, is basically go parallel to the vessel, right, first. So you can see here, it's all the way over here. So I'm going to give a little pinch around 10, right? Okay. Sorry.
Yeah. Sardar, remember, we also need some room for our sheath in the SFA to be as close to the common femoral. So it might look it's almost approaching the mid SFA segment, but that's the only area we have because we need our sheath to be introduced to give us access because first you have to fix the common femoral. So you'll have a tendency of going close to a CFA because you want it to be close to the CFA, but here we have to come at least 10 centimeters more distal. So that way our sheath, there's enough approach and enough stability to the sheath to fix the CFA. So
absolutely
the good thing
agreed. Very nicely explained. Yeah, wonderful. So obviously
and
we see.
The good for us is, like you saw, the proximal SFA doesn't have as significant.
Put me on coronary, guys.
So hopefully that's a savior for us because remember, let's say if you had a SFA, significant tight lesion there as well, so then we're again stuck. But
I mean, in such a case, you see how much calcium can be your biggest enemy as an endovascularist, but also a kind of a friend by giving you a kind of a roadmap to obtain an access.
Yeah, really. You're absolutely right.
Oh, it bounced off.
It's moving the vessel right there. No. This probably rolls.
Mm-hmm.
You see how much the artery gets dispositioned with the needle because it's so calcified.
Yep.
Wow.
Right.
Watch your knees.
Impressive.
So we're off.
Yeah. A little bit of liposuction, but it should work. Oh, arm we have to tie.
Wow. The artery is unable to penetrate the calcium. I mean the needle.
The needle. Okay.
Cook.
Wow.
There it is. Yeah. Nope, it just bounces off.
Huh?
Nope.
Yeah.
Okay.
These are the challenges of calcified
Well, like I
arteries.
said, nope, not able to do it. I'm right on top of the artery.
I'm sure.
Nope. All right, let me.
Maybe a steeper stick.
Yeah, I don't really want to, but
I agree.
Yeah, but sometimes in some of these cases, it's just sometimes you just might have to go with your direct cook needle.
No, you don't want to do that here, because you want to make sure that you're able to. But remember, you want to keep the safety of the patient in mind. You know. Man, I've done a lot of these. This is hard. Just bouncing off.
Do you want a roadmap?
No.
No, you can see the artery.
You can try a spinal puncture needle. It's also an 018. Probably has a longer.
No, I don't think it's a question of 018 versus 014. Yeah. It's a question of the ability to push the needle through the penetrate the calcium. Back up. I really don't think it's an 018 versus 014.
Oops, sorry. My bad.
All right.
Sorry, Ray. I know. Man down. Ooh.
Well, I wasn't even close yet. Now I'm close.
Wow.
No.
Yeah. Finally.
Okay, that's a nice stick here, exactly in the middle.
Yeah.
Tell me about. Watch out, right?
Yeah.
This is the stiff wire, right?
Damien, 5 French sheet. 5 French sheet.
The idea is you're going to have to cross this from below.
Oh, yeah. Now here a roadmap problem. The micropuncture wire also can enter planes.
Mm-hmm.
So yeah, you always have to be.
All right, let's give a roadmap from above.
Yeah, let me do a mag out first. Okay. All right.
Ready?
Whenever you are.
No, guys.
My bad. Not ready.
Okay, off and on.
My bad.
So, Dr. Krishnan, you truly selected the most challenging case as the last case of this academic semester for our fellows.
Absolutely. All right, give me a stiff micropuncture sheet.
Right here.
Okay, let's now. This is a stiff wire, right, guys?
Yes.
Yes.
Okay.
Stiff mic.
Careful, sharp on the table here.
We want to just use the first dot.
Do you want supercore instead? Can you grab a supercore again? Short.
Okay, good. Nice.
Okay.
Short one.
Nice.
Can now give me a glide wire? Stiff angle glide.
Okay.
Stiff angle.
Dr. Krishnan, any reason for the preference of the stiff glide wire over an 018?
Well, at this stage, you don't want to lose the wire access in the vessel. So therefore, you definitely want to go with a stiff glide. Okay.
Okay, let me do that.
I'm not able to get it in.
I gotta introduce him.
No, he's moving, Liz.
Okay. There we go.
Liz, he's moving.
Let me. Take some wet one.
Okay.
Okay. Wow. This is
Nice.
Can you bring this monitor closer to me, Damien?
Perfect.
Here's the torque right
That's
there.
from the top.
wonderful.
Okay. Save that, you guys. Okay.
All right.
Show me above. I got to get into the aorta.
Yep.
Where's my wire now?
Right in there.
25. 20.
Can I have a torquer on this wire,
Yeah.
please?
So that's a nice demonstration how you crossed it. Any particular technique, Dr. Krishnan, for the audience using the glide wire?
I mean, honestly, just use a dry gauze and then try to go up.
Okay.
But here the problem is visualization of the tip of your wire is very important.
Yeah.
So you need to really see it. You can see how calcified this is and how challenging this is.
Yeah.
So the idea here would be making sure we're in the right plane as we cross, you know.
Yeah, I guess he's right. The biggest limiting factor is we don't have any support catheters.
Okay.
Remember, we have a micropuncture sheet, so we can't put even a support catheter. Normally, you'll be able to put a support catheter and direct your wire. Here, it's
So the question here is whether we need to snare from below.
But that should give you enough length for your sheet to put in.
I don't know, bro.
Because it's stiff wire. Hopefully, we can do a micro dilator first and then put a sheet in, and then we
probably
can use
then
our
with
micro catheter support.
yeah.
I mean,
Or a
there,
Navicross.
of course. Sorry, I'm going to go a little bit empty.
But I see Dr. Krishnan likes the challenge. He's maneuvering already the wire across.
No, I just don't
Did
want to
you?
get. I just
Right,
watch your shoulder, Ray. I just want to have the wire in the aorta to have full purchase. I'm trying to see
You're
where my
almost
wire.
there, Dr.
He,
Krishnan.
he wants his whole value.
Where's the
for money.
wire?
It's looped in.
It's by the
at
loop.
Right there. That 21, right here.
No, I can't see.
Hold on, let me mag up for you.
No, I can see it. I just want to.
Yeah, right at 21.
Let me move this.
Can we pull the wire from the
from the top?
radial sheet
Yeah,
off?
hold it. You have the sheet? Yeah, I'm going to pull it.
Okay, I need some help here.
Good.
Okay. Your wire crossed already. Wow.
There.
You are
Probably our
wonderful.
wire was
Very
Are we
nice.
above now?
Yeah.
Just making sure that I got to move the wire to make sure I'm in the aorta. Does it look like it's behaving like it's in the aorta?
Yeah.
Yeah.
It's free.
Is it free?
Oh, it's spinning. Look.
Yeah.
Okay, now give me a 5 French. Oh, you want to go with a 7? Or
No,
because we can go with a 6.
So
Let's go with a
Dr.
6. 6
Dr.
French
Krishnan, a
25.
question-
Dilator first, yes.
Yeah.
Do you want to
Question
dilate with
for the
five?
audience:
Yeah, give me five.
why were you hesitant with the wire position in the
No,
aorta?
dilator first.
No,
Dilator,
but there's
dilator.
5 French.
I know, but I
Dilated
got to
with a
take
five.
this out.
Okay.
So 1 second. Let's take. I'll show you, sir. Though 1 second. I got to take this micro sheet out.
Absolutely.
Inject from
25.
above, guys. Inject from above. Ready?
Here.
I just want to
Above.
see where we are. Okay, we are in the aorta. Again, guys, you have to make sure you're in the right spots with everything, right? So right now we have a stiff glide. Now I'm taking my micropuncture sheath out, and Vishal is ready, and it's going to bleed. So I'm just going to hold SFA pressure. Okay, and now we're going with a 6 or a 5.
We have a 5 dilator.
I'm going to use a $5 and then go up with a 6 French.
Okay.
Okay. And the 6 French, what length are you gonna
25.
choose?
25.
25. Okay.
Mm-hmm. Okay, the dilator is in. Okay, good. Wonderful. Now I'm going to take the dilator out, and Ray's going to hold common femoral pressure. Okay.
So in anticipation of the next steps, Dr. Krishnan, what would be the therapy you are intending to choose for the CFA and the common
Well,
ilia?
first we need to open. Show me down now, guys. I got to see down.
Yeah.
Okay.
Sorry, Ray.
Okay.
Hold on.
I need a nick here, Ray, right?
Yeah, I think so.
Yeah. Come back down. Somebody has to make a nick for me.
Watch your hand.
Ray, you holding common femoral pressure?
Okay. Let's try.
Don't pull the wire.
No.
Not going.
All right, give me the dilator.
Okay, give me the 5 French sheet. Let's put the 5
Yeah.
French sheet
Yeah,
in
that's
first.
right.
Yep.
So obviously the challenge here is to insert devices into for arteriotomy
wire.
of such a calcified artery.
Okay, this is in. The sheet is in.
5 French
Let me
sheet is
see.
in.
Let me see it. Show me down. Show me the
I want to
sheet.
see what my wire is.
Your wire's in the aorta.
No, but
Let me try to see if I can advance my wire.
yeah, no, that's what I'm saying. I want to see what my wire is. Yeah.
Follow the wire, guys. I don't
Yeah,
want it to go with the renal.
Would it be a possibility to exchange this wire to a stiffer wire through a vertebral catheter?
Yeah,
Well,
but
right now, I got to be honest with you. Right now, we just need to get the sheath in.
Yeah.
Let's get the sheath in, guys. Now, Ray, you got to hold common femoral pressure. It's going to bleed a lot. So not yet, Liz. Yeah, you can, Liz. Give 5. 6 French. So right now what we're doing is, so the key now is to now make sure that this doesn't cross the lesion into the common femoral, right?
we need a 7.
Yes, I got it. Show me down now. You can let go, Ray. So now I'm just, see, I've got my dilator with my sheath. So I'm going to advance my sheath to that spot. Now I'm going to walk out my dilator. Now I'm going to do a couple of things. Now we're going to settle down, take some pressures. All right, so the pressures are good. So now I've got my wire across, up and over. I'm going to pull this wire out. Put the light on, lie down.
If you
Lie
use a
down.
6 or chocolate, it should be
Okay, so give me a Terumo Navicross, guys.
Yeah.
Okay, this wire just came out easy. Okay, this wire is out. Okay, so I'm going to take this
Okay.
wire, put this in the aorta. It's not going.
Yeah, let me give you a micro.
Oh, it's fine right now. Let it just stay here. Actually, let's put a microcatheter in this. I'll explain to you guys why. So now, like I said, now is when we're going to work. So now we're going to have to exchange this for a, why is it bleeding? Huh? Is there any hematoma? No hematoma. You just watch that carefully. Are we in the vessel? Because sometimes it may get pushed out. Yeah, we're in the vessel. I just hold a little slight
it.
pressure there, right? Okay, so what I'm going to do is I'm going to take a Navicross. Don't lose that other wire. I'm just going to go ahead, go here. And let's just advance this slowly. Go. Okay, you know what? Go with the woolly.
Yeah, I don't like that.
Get him a woolly wire, guys. Let's get him a woolly wire. So you can see, so now we have 3 accesses. We have a SFA access, we have a radial access, we have a contralateral common. Now I'm putting this wire up into the aorta, and now we'll start with the procedure in a second. We're going to have to upgrade this to a 7 millimeter. What size VBXs do I have that go through a 6, guys?
We have a 7 now. Oh, through 6.
Uh-huh.
So obviously here you're already anticipating the challenges with our endovascular devices with regards to wire commodity and the length and actually the sheath requirements.
Now SuperCore here on this one. Yeah, exactly. Yeah. So what I'm doing is obviously now we're putting a SuperCore wire up. Actually, you know what? Give me a Lunderquist. I'm going to put
this is a case where I have to tell our audience that this is a case outside of clinical trial data. So here a lot of expertise is required and a lot of knowledge. And therefore, we are not talking that much about data until now because there is no data for such an intervention. These are like seldomly done, right, Dr. Krishnan?
Well, yeah, this is, so we're going to put a Lunderquist wire. Absolutely, you got it out. You hit the money on the nose there. And what we're going to do is we're going to put a Lunderquist to have plenty of access in terms of any sort of intervention that we need. We're going to be able to do it. If God forbid, we need to put an aortic occlusion balloon, we're going to do it. There's a Lunderquist wire coming out, right?
Yeah.
Good. Okay, now he's going to walk this out. So we have plenty of access here with the Lunderquist. So now I'm not going to put 11 French sheet, but it's going to be open on the table.
Okay.
The 11 French sheet open on the table.
Okay.
Okay, so now we are now ready to do our intervention. So before I do that, I need to now change this to a 7 French sheet, and I need a stiff 014 wire for the shockwave device.
Correct. So always remember, a 7 French shockwave goes through a 7-0 balloon goes through a 7
whatever
French
balloon.
And the
don't we have an Atlas balloon that goes through a
shockwave on the left side as well? So that's why we're going to upgrade from a 6 to a 7.
You want a Grand Slam? Stiff 014 wire?
Okay.
What? Yeah.
Yeah. So give me put the Navicross on this wire now.
So selection of the 014 wire was because of the usage of the shockwave.
Exactly.
Which wire are you guys intending to use?
We're going to use a Grand Slam wire.
Grand Slam.
And then we're now going to go and put this up.
Maybe put a Lunderquist on this side as well to give us. It's such good to track our sheet. Okay.
We could. But this is a very tight lesion.
Yeah.
Microcatheter might not cross, right?
No, it's not crossing.
Crossed, not? Okay.
Now it crossed. Okay, show me above. Okay, good. Show me above. Okay.
Oh, there it is.
Now pull out this wire. Put a SuperCore up. In the OR.
What do you need?
So whichever the 11 French balloon is.
The
Coda.
The Coda is 11 French, isn't it?
Yeah, and the Reliant.
So obviously you guys are discussing possible the need for an aortic occlusion balloon.
Right. Coda is usually a volume-based balloon.
Yeah.
Any preference, Dr. Krishnan, with regards to use of aortic occlusion balloons?
Well, we want to go with the shortest sheet. I mean, the one we had was a 16 French sheet, which is not going to work.
Yeah.
We need another tech in here to get another set of hands. Right. Right now we're doing a very crucial procedure. So what we're going to do now is we're going to change out this sheet. Right. So Ray and I are going to hold pressure at the level of the common femoral. Hold on.
Take your time.
All right, go. All right. Okay. 7 French sheet. Can I have another tech in here?
The
bleeding?
Please, can you give me an epi ladder? Yeah.
Go. Just don't cross the lesion. A little more. Dilate her out and sheath it.
Yeah.
Push it forward. More. Or you're not in the vessel.
No.
More.
I am just.
Okay, stop there. Okay, walk it out. Nothing. I just need Epilyto. Okay. All right.
Let me flush the cheek one second.
Everything good? Huh? Yeah.
Yeah.
Everything is good.
Here's Epilyto.
Okay. You don't need Epilyto.
It's okay. I'll take care of it. Don't worry.
Yeah.
All right. So now, okay, now we got everything up and over. We're going to recheck an ACT now. I know. I'm going to recheck it.
This is Epilyto.
Recheck the ACT. Now give me, now we're going to switch out this for the 014 wire. So this is the problem, guys. So now we're going to have to go with an 014 wire to do this this device. So before we do this, we need to take a picture. So can I have some dye, please?
Yeah.
Just going to inject this injectable dye here.
Yes. Yeah.
Okay. So what I'm going to do is I'm going to do a DSA,
So, PK, what's your strategy? First,
common femoral, and then up.
Up.
You
Okay.
ready?
Any recommendation with regards to advanced imaging,
DSA?
maybe an IVUS or so for this?
At this stage, no, I don't want to do anything advanced.
Okay.
I just would like to just do whatever we have, whatever we can do to get it forward. So here we have good flow, we have flow down. So now what we're going to do is we actually don't even need any contrast. We can just do it under this one. So now, okay, so now I need to replace this with an 014 wire.
let's put the Navicross. Right.
So the idea here would be is I'm going to go with a 6-0 balloon at the level of the common femoral,
Correct.
and then go with a 7-0 balloon at the level of the iliac, and then I'm gonna. The problem here is the reason you need to have everything in place is if there is a rupture, you want to make sure that you're able to replace this contralateral sheath very quickly with a what is it called, large sheath to put a coda balloon up. Okay, so what wire out now?
It's up, right?
Yeah, I'm up enough, far enough. Okay, now put an 014 wire in. Make a big C loop, please. So I have my balloons and everything, my large sheet, balloons, everything here.
Yeah.
Okay.
So you guys are gonna try to treat the CFA first with a PTA, with a plain balloon, or with the shockwave directly?
All the way up. Well, we're going to try to do it with the shockwave directly. Walk it out.
Okay.
So I'm fixing the sheath as Dr. Kapoor walks it out. Okay, and it's out now. Okay, good. Now the wire's up. Now we're going to give the PTA. What's my repeat ACT? Shockwave, guys.
I got it. Get.
And with regards to definitive therapy, any plans for the CFA lesion after the shockwave, a DCB
6-0.
or?
6-0 shockwave.
I know Dr. Krishnan doesn't like the idea of stenting the common femoral.
No, if we have to stent this, we'll stent it.
Can you zero both for me, just one time?
You have ACT? ACT, guys.
Okay, here we go.
And would there be any additional role for additional atherectomy modality, like directional, or in this case, especially in the common femoral artery, because it's so an exophytic calcified chunk?
I think, you know what, if you know, with the CLI and such a gradient, if I can get a lumen of any sort without dissecting it, I'm going to be really, really happy. So I'm just going to go in. I may actually track this across the common iliac first, shockwave balloon it, but I want to make sure I have my bailouts available before I do anything. So at this stage, all I want to do is make sure I know I can control the common femoral if I have to from where I am. At this stage, I don't know if I can control my aorta. So therefore, I need to be thinking about how I can control the aorta if anything happens. So it's an eccentric calcium. I want you to just On the fluoroscopy, look at where the wire is crossing, and you can see how the wire is very eccentric. So since the wire is very eccentric, the chances of any sort of rupture may be an issue, so you have to be ready. Second, the issue is if you do have a rupture, what you have to think about is how am I controlling the aorta where I get everything ready. The most important thing is not to panic. Pressure is down a little bit. I'm assuming it's because of the hydralazine Elizabeth gave.
It's not diluted.
Liz? Gave a little bit? Okay, so 0.5 of hydralazine has gone in, so pressure is down a little bit. 5. So therefore, now we're just watching. So what I'm going to do now is, as Vishal do this, but anyways, I was telling you my train of thought. What I would like to do at this stage is make sure I have everything ready. So if I rupture this iliac, I'm going to have to get an 035 wire up. So I need a coda balloon to occlude the aorta. And then I need to be calmly put a stiff wire because I'm working on an 014 system. So as much as cardiologists love 014 systems in the endovascular space, it's not necessarily the right thing because remember, your bailouts are all very, very large vessels. So at this stage, I'm going to ask Ray to let him know, and then we're going to just start. So we're just going to go forward here, but I'm not going to do anything. I'm waiting now for my balloon before I do anything. So once my balloon gets here, I'm going to go ahead and start. So in the meantime, let's talk about anything else. So what's going on? So what's everyone doing for the 4th of July?
Okay. One question from the audience, Dr. Krishnan. A question comes with would an hybrid approach be a possibility for this patient?
Absolutely. I think a hybrid approach would have been probably a more prudent approach to this. Unfortunately, the family was really not for a hybrid approach since he's had issues in the past. He's turned down bypass and this and that. You know, like I said, it's like walking away from this procedure is not a bad thing. You know, you can always walk away if but the idea is when do you walk away? At this stage, everything is going really, really well. You can see we're very patient at this stage. We're looking at the waiting for the balloon to come up from the OR. We're talking to our surgeons, letting them know what's happening. And then we're going to go ahead and start. I'm not in any rush at this stage. And I think it's very important for the audience to understand that. But to answer the question, a hybrid approach would have been great because you'll have full control of the common femoral, and then you'd be able to do it. But the idea here is that you can do this with a percutaneous approach. So one question is how do you get hemostasis of the SFA? So that's why we have our what is it called? Metacross balloon to go through the long Terumo sheet to cross. So right now we don't have a wire across. So the idea would be is when do we get the wire across? Would be after we put the covered stent, we'd have to cross with a wire from above and down into the SFA. Yeah, I think so. That's what we're doing.
No, it's a good idea. Sardar, they bring about the hybrid approach. It's always, like you talked about, feasible. Do an endarterectomy at the entry point. You create pretty much like a new road for yourself, and then you can get access bilateral and then fix your iliacs in a staged manner. So it's always good to have a hybrid approach. Get the surgeon involved like PK always does, especially in this case, as a backup and as a primary both. And then, come up what's best for the patient. So definitely works. But
So at this stage, Damien has got the balloon, something in his hand. I'm just waiting for him to come in. Ray has called our surgical colleagues, letting them know that we're about to balloon the very, very calcified common iliac. It's part of our responsibility at this stage to make sure that everything is set and check our ACTs. So 280, so it's a good ACT to have. I'm just going to step out for a second and see what's going on. Can you mute my phone, guys, while Vishal talks?
All right, Sardar. So in the approach for the SFA, I think it's a good, here the advantage, like I said, it's a good size SFA, so we'll be able to get access and hemostasis both from outside and inside. There are multiple options. What's your thought process on, I guess once we come to it, but what's your thought process on closure of SFA sticks? Let's say,
that's a very good question. I was planning to ask you guys. So would be a closure device an option for this patient or not? Since most of the closure devices are officially not intended for an SFA closure.
No, you're right. I mean, they're not approved for SFA stick closure. So I mean, you could use closure device if you have to. Uh, but again, I mean, we know SFA sticks because it's deeper, it's harder to get hemostasis, more chances of having a pseudoaneurysm at that point with some hematoma. People have tried, I've known, like personally, again, off-label, I've tried different devices. They've done MINCs, they've done the extra vascular devices, you know, like you have the Exoseal, the MINCs, and the Vasoseal, all these devices, Vascade, which could be tried in this case, so that way at least you can try to get some hemostasis. Personally, I don't know if anybody's tried Perclose in the SFA stick. I mean, the lumen size is good, but again, that calcification and the depth itself might end up causing more trauma to the tract and the vessel than getting the advantage. So you could try one of these extravascular devices, and the advantage here we have is that we have an intravascular approach. We can, through the R2P sheath, we can do a balloon tamponade from inside. So God forbid we fail, we still have plan B ready right there, and it'll give us good hemostasis.
And with regards to the choice, would you prefer an closure from an extravascular closure over balloon tamponading it with regards to the development of pseudoaneurysms?
No, in this case, I would probably...
that manual hold for SFA is very likely associated with a pseudoaneurysm?
Correct, I agree. I mean, in this case, I will definitely just empirically go in with the intravascular balloon dilatation to get hemostasis from inside, keep it up for 5 to 10 minutes max, and then a little pressure from outside. The other thing you could do, a lot of people do, is if you think you can get pressure enough, you can have a large blood pressure cuff around the thigh and just inflate it above your systolic pressure to give the hemostasis from outside as well. You know how we do in perforations of the in the arm and in the thigh, you can put a blood pressure cuff, and that could give you hemostasis from outside as well. So it's like double hemostasis. You can have it a balloon tamponade from inside, and then if you want, you can have a large blood pressure cuff on the thigh, which is above the systolic pressure. Just again, like you rightly said, decrease the chances of any hematoma or pseudoaneurysm. So
absolutely.
The boss is back.
Let's go. Put my microphone on. All right, so I just want to make sure that I'm checking everything. Lo siento. So you may be having a little hematoma going on here. Let's take a picture through this. Ready, guys?
Oh, no, hold on. I need to give you a hand injection for this one. Because we don't have... Oh, sorry. Give me the bigger one. I think it's just pain going through the thigh. It's actually...
Okay, it's actually very good. Okay, good. So let's... so we have an XXL balloon, which goes through an 8-French sheath. We're gonna put 6. We're not gonna put the sheath in right now. We're gonna go forward. We have continuous pressure monitoring, and so we're just gonna go ahead and balloon the common femoral right now. So, wet one, guys. So the problem, and I'm not being disparaging to any company by any means. The issue here is you want to do complex things in your life. And these things, just are not ready to do complex things, So if you don't have, it crossed. So now we're going to go up with this. As we watch the pressure, ACT, Elizabeth said, was 289. So we're just going to go. I'm using a 6.0 Serdar again. I don't want to dissect. I don't want to dissect. I don't want to dissect. I'd rather get just a lumen. The lumen is so tight right now. If I get any sort of lumen, I'm going to be fine.
Okay. I mean, with the amount of calcium in this artery, I think the Shockwave is the perfect selection for plaque modification.
Yeah, I was thinking sometimes you might have to pre-dilate with a smaller size balloon if this didn't go, but this went, so which is good for us. So we'll do the Shockwave therapy here.
So we're just doing a nice Shockwave of the common femoral, and I'm going to go up and do the external iliac as well. So, I mean, this is the issues. I mean, these are some of the issues that we're dealing with. I agree with Vishal. I don't mind angiosealing. Do one more. Yeah. I don't mind angiosealing this SFA if I have to. To me, it's and I've got up and over if anything bad happens. But I think at this issue right now, we got to get hemostasis, and with calcified vessels, it may not work the way we want it to.
Yeah.
So therefore, this is the situation here that we're doing.
Yeah.
So Shockwave of this, we're doing two therapeutic deliveries of this device. And then I'm going to see if the deflated Shockwave will track across that proximal iliac, which I think will be very, very difficult.
And would be for the usage of a closure device and failure of a closure device a reversal of the heparin with protamine an option in this patient with CLI?
6.
I'll go one more time and just do one more
Yeah.
section before
6 and
before
down.
you track it.
Okay, down.
One
So
second.
I'm just going to go forward a little
Just
bit.
touch. Do one more time.
Okay, go up here.
Oh, this balloon now tracks nicely, actually.
Yeah.
Yeah, because we've now had the ability to go to 6 now.
6.
So again, we're delivering shockwave therapy here.
Any ideas how many cycles you anticipate to use?
You know, honestly, Sardar, for me, it looks expanded already,
Yeah.
and I think it's a 6.0. And I remember it was very difficult to track this balloon deflated. So I'm just looking for a lumen, Sardar. Honestly, a lumen is all I want. I want a lumen, blood flow down. We know he's got good runoff to the foot. It should be more than enough without losing the profunda would be great, you know, and without putting a stent. Let's see how it goes. Done?
Do one more.
Okay, one more.
Yeah.
We're going to do one more.
So after this, we still have 6 more cycles left. So if you want, you can actually track it up, give a iliac a little bit of expansion with the same balloon. Then we can use more 7 on the right side and a few, we use 7, but they have enough cycles for us to use both sides of the
Okay.
balloon as well.
And maybe Dr. Avadani can explain to the audience how much is the pressure you initially go up with the shockwave balloon, and how much is the pressure at the end of the cycle.
So I think they just want vessel wall apposition. So we go low atmospheres,
Down?
either 2 or
Down?
4 atmospheres. And then once you deliver the pulses, we just went up to 6.
Correct. We just went up 6,
Cool.
go up just to see
Very
the pliability of the vessel and the balloon. Hold on.
Nope, not going. You want to just go? You want to go up or no?
Yeah. Just go up a little bit.
Not going.
No, it won't go.
I think there was also a lesion a little bit on this
right.
side where you guys are right now.
So walk it out.
Yeah.
So we're going to go with a regular balloon now. You're going to give us a 4.0 balloon, guys. 4.0 balloon. 4.0 balloon. You stay there, right?
40.
So obviously there's no pressure drop, so we are in a
Actually,
safe position.
Yeah.
No.
A 4.0 60
40,
balloon.
60.
Okay. Almost done. All right, let's take a shot from above, guys.
Yeah.
Ready? Okay, my friend, hang on. Don't move.
Okay. Ready when you are. Probably I'd say the hard flex. Okay, one more time.
Okay. So you can see the eccentricity of the shock wave. It has to go through that eccentric calcium.
Yeah. Yeah, it's like more like a stepwise approach. You have to slowly go up on the balloon to create a track. And then
Absolutely.
deliver our gold therapy balloon, which is shockwave, and then hopefully.
I have wire.
Okay, now I'm gonna go. If this doesn't track, this is where we may abort. You know, we gotta be very practical with what we do, and it did track.
Yeah.
So now we're gonna go up slowly. So, usually I like to change my underwear once a day, but today may be an exception.
Or just go commando.
Let's go
Put me on
commander.
coronary, please. Watch this over. Right? Okay, you up?
I'm at 8.
You're there. I don't even see anything.
Yeah, I think the
Yeah,
calcification,
down.
the dilution of the contrast.
Down.
Let me put some more dye.
Okay. Okay, hold on. Let me just go up a little
Yeah,
bit.
yeah.
Make sure it goes. Okay, walk it back now.
Want to do one? Okay.
Okay. Go up and do
I'll go
another one.
back. Yeah, I was gonna say just
One
do
sec.
one more up.
Okay. Let's do another one to 8.
Good.
So balloon tracks even after being winged. This is a good sign.
It's a good sign. Let's go to 8.
I'm at 8.
Okay.
Nice. Okay, let me fluoresce.
Get down.
Yeah.
Okay. So now we got to watch the pressure as we come down. I mean, a 4.0 balloon is not a benign balloon, guys and ladies and gentlemen, so you got to be careful. Okay. Let's take a nice DSA from above when you get a chance. Okay. Okay. Ready?
Ready when you are. Oh, what
Sorry.
Yes, sir. That's okay. Go. Okay.
Okay, we got
Same
better
great.
flow.
Nice. Some lumen.
So now give us a 7.0
Okay.
shockwave now. Or you want, yeah, let's go. You want to go with a 6? Let's go with a
the
6.
six,
We
yeah.
have more pulsatiles available.
But it's a flared up 6 versus a collapsed 7, so probably.
I mean, we'll try. If it
new
doesn't go,
7.
we'll go with a 7.
And
So-
Dr. Krishnan, stenting this common iliac artery would be the destination choice.
Oh, there's no question. I think we have to go with a VBX. I think we go with a 739 XL if we have it, or a 739, and then we post-dilate it to an 8 is what I would want to do.
Okay, and for the contralateral side, Dr. Krishnan, any plans for the?
Honestly, at
right.
this stage, I think Elizabeth will smack me if I start talking about that. So because I think that, this is, if we accomplish this without an issue, I think we'll be okay.
Like, who's
Perfect.
Elizabeth?
Okay. I know, I'm picking on you. Hold on.
Elizabeth is saying, who's Elizabeth? I don't know.
I don't know who Elizabeth is. All right, let's go here. Is
Very
it
good.
across?
No, not yet. It's coming now. There it comes. That's the proximal at 19. I think it's a winged balloons.
No,
It's
you're at,
it's moving.
you
It's
went in
moving.
a bit. 18.
Yeah, we're at 18.
It's moving.
Oh, it's not going though.
Yeah, it's not going where it's winged.
Yeah, let me see.
Maybe
25 and
maybe one cycle at this level would be helpful.
Yeah, but that's where we're stuck.
Oh, yeah.
Yeah, now it's crossing.
Okay, Lucky, that's
Nice.
enough. Let's go up here.
Yeah.
Ray, where is he?
It's at 18
Mhm.
or 17.
Yeah.
Okay, ready? Go up.
Going up.
Let's go to 2.
Mm-hmm.
And now shock.
Yeah.
Nice.
I'm going to put you on coronary.
Yeah. So that the visuality will become better. Looks expanded a little bit. Almost.
Yeah, I was gonna say approximately it looks a little bit better. But,
Eccentric though.
yeah, the wire is so much biased.
Yeah.
You just have to.
I think the waist is at 20.
Yeah, right at between 19 and 20 is where the real waist is.
Mhm.
Okay,
Okay.
done.
Go up.
No,
Yeah.
down. Go up again with the
Can you reset, Tim?
reset the shockwave, please.
Yeah, it's set. It's good.
2.
It does.
Go to 4 now.
4.
So the initial inflation pressure this time is 4
Yeah.
atmospheres. Mm-hmm.
So normally you'll go 2 to 4 inflated, and then before you deflate down, you actually go up 6 and then come down, just to give it that last push to crack that calcium up, and then we just take it down. So that's the normal.
How's the common femoral field, Ray? Any hematoma? Good. Okay, down.
Down.
Okay, now I'm going to just try to get some speed and go up.
1 second, let it come to life.
Let Vishal bring it back a little bit.
Let me get this slack out. Okay, go. Try now.
And rail the wire, please.
Yes, please. It's right there.
Nope. Okay,
It's
give us the
wings,
7.0
sorry.
shockwave, please.
And the idea of opening this this narrowing here with a monorail balloon for maybe 4.0 or 5.0.
We did do 4.0.
Yeah.
Yeah, we do.
So at this stage, I'm going to go with a 7.0.
Okay.
Okay.
I think the 6.0 went almost all the way. So 7.0 unwinged, unused balloon, I think should be able to track through it.
Okay, my friend,
we're just
almost
hoping
done.
For the best. So.
I'm going to check my sheet here. Okay.
Would it be an option, Dr. Krishnan, after doing the shockwave ballooning of the common femoral artery to advance the sheath over a dilator across the common femoral artery so that you have a little bit more support with your sheath, or
I
is
was
this not
just
a good option?
Well, it is an option, but like I told you, I don't want to dissect. So at this stage, what I'm going to do is I'm just going to take a picture of the common femoral to see how it looks, and then decide. I mean, if it looks really good, then we can do it. If it looks bad, then we're not going to do it. So I'm just going to come down here and just have Ray just, be careful as I just inject here on the DSA.
Hold on.
Okay. You got it?
Go.
So
it's
still,
definitely low.
yeah, I don't want to touch it. It still looks bad to me. I would not take a sheath across that. I have a much better lumen, but I would not take a sheath across that at this stage.
And I guess the biggest factor if you look at it is the profunda is still there. I mean, that's the one thing that's the lifeline for this case. So if you start seeing getting profunda jeopardized, then I'm sure PK is going to start back up and say, okay, what's our plan B? But here the profunda still is robust and going down.
Yeah.
So that's a good, healthy sign. So now we're going to take a 7-0 balloon.
1 second.
Ready?
1 second.
So we're going to go up. Are you ready to rail?
Yeah.
Once.
Give me one. She's hooking it up. I don't want.
Yep.
Okay.
Hopefully this goes.
Can you give us some tegaderms?
Go, baby, go.
Yeah, it seemed to have
Yeah.
gone.
Wonderful. Wow. That's a good. That's a good demonstration that even the balloon is bigger than the previous one. The fact that the previous one was already winged speaks a lot that it takes more lumen, and this artery still needs a lot of modification.
Yeah, I definitely think we need a lot of modification here. And now my concern is how am I going to track my stent across this?
Yeah.
You know.
And that's still one.
Okay, two,
Two.
and then start, please.
Yeah. Or at least the balloon is expanded decently. I mean, except for the tightest spot right
Liz,
here.
fix this mask.
We can see it actually opening up right there as well, between 18 and 20.
Okay,
Yeah.
okay.
Or so.
Okay.
Okay,
I think that's
do it again.
Yes.
So I'm going to treat this as much as I can. And then start.
No, it has to
Oh.
reset. Yeah. It takes a breather.
Okay.
So you can actually see we didn't even go up with the inflation, but the mid segment is trying to open up as well. So that's another sign that the calcium is actually working. So
How many atmospheres do you have on the balloon pressure?
right now, we just kept it at 2 because we want to be
At 2.
minimalistic, especially with the eccentricity. So maybe next one, when PK tries to push it a little bit higher up, we might go up to 4 and then do another run, or at least a couple. Another one. We still have enough for the other side.
Okay, so now what I'm going to do is I'm going to go down. I just want to see what happens to my pressure. Obviously, you always want to be cognizant of what's happening, and it's going to drop because you're going to have a little bit of release. But then what I'm going to do is come back now and go right about there. Go up again. And this time we're going to go up to 4. Okay, 4 atmospheres, go.
Okay, that looks good.
Mm-hmm.
Nicely expanded.
Yeah, but he has no ulcer on the other side, so. Well, Ray's concerned because there's a big pressure difference.
Yeah.
And what I'm going to do now is switch it to the SFA to see whether we have a pressure difference after we stent, and then we'll decide how we deal with the common femoral. Okay, my friend, hang in there. He's going to go pee-pee. Sardar, what's the Arabic word for pee-pee?
I'm sorry, I cannot say this.
Say it online.
Live on. I really apologize.
Why? The poor. I don't know what's going on. Okay.
So the medical term is bowl.
Does he have to go bowl?
Bowl.
No, bowl. No pee-pee. Okay, go.
It's a
Okay.
universal term, so I don't.
Pee-pee is universal. Let's go up again to. Actually, let's walk it back.
You don't want to go any further more?
You want to? Okay, Vishal. Okay. Oh wow. Okay.
Yeah.
Okay, now you're definitely in the aorta.
Yeah.
Okay.
You go.
Go up.
Because still with the center, we're still a bit lower. I know it's not osteal, but at least it's a little bit more.
So the biggest, the strongest oscillations and the strongest shock waves come from the middle portion of this device.
Right.
So tracking it up to a little bit into the aorta makes the plaque modification actually the strongest at the tightest lesion.
Right, exactly. You're absolutely to the point. So that's why I wanted to a little bit higher up so we can get our oscillators right at the proximal. It's not ostial, but it's proximal for sure.
Yeah.
All right. Once we do this, oh no. Everything good. Everything good. I need now. And I'm gonna walk this back. I'm not gonna deal with the common femoral yet. Now, when you come back, I want to see the pressure.
Yeah.
Okay, right there. Stop. Pressure is good. Now we're gonna do a DSA from above, and then I need an 035 wire. Ready to inject?
Ready to inject.
Okay.
Oh,
Would you like to?
1, 2. Yeah, DSA there.
Okay,
Nice.
very good. All right.
More lumen.
Now give me a Terumo Navicross wire.
Let's walk.
I mean a Terumo Navicross and a Supercore wire, and give me the VBX. 70, 39, or even 59 is fine. I will after the VBX. So you can use a VBX or a live stream, but VBX is fine. We're using VBX in this case. And I need a Navicross.
Yeah.
Because remember, this is not going to cross with anything other than a 035 wire.
035 wire with a lot of
Yeah.
support. Yeah. And any tips for the audience why you prefer the VBX over live stream?
I remember they both are excellent stents. I want to go on the record as saying that the VBX obviously allows you to post dilate if you need to. The nice part here is you have a wonderful landing zone that's available, right? Is somebody railing me, I hope?
Yeah.
Okay, so good, we're through. Okay, now I would just want to go ahead and I'll send up the wire now, 035 wire.
I'm taking this out.
Yeah.
035 wire.
There's a supercore going up.
So it's actually very important for the audience
You want a
to see
59?
this case has been started with the accesses live, and we are at 1 hour and 3 minutes since we started the procedure, and we are already at the level to deploy a stent. So just mentioning it for the audience that these procedures are possible and doable, and you just need to be very careful with planning and
think you're right.
adaptation to challenges.
Exactly. It's all about like patience and watching, and there's multiple steps, but with patience, I guess it gives a little bit more control environment. Of course, you need good wingmans, which PK will agree. We're missing Dr. Guja, but
Yeah, but I mean, look, right now we're right about at the stage. He's very uncomfortable naturally.
Yeah.
Now this is when we all say a prayer, right? We want this to cross easily, you know, and wow. Nope, walk it out. Oh, he has to go pee-pee now. That's good. Okay, we're gonna give him a pee-pee. Give him a pee-pee. I'll wait. Go and see where he is. So now we're not able to cross. So the question now is, No. Okay, Shreya, go over there, please. You go, Ray. Sorry about the screams. It's because he moved his hand and he has a radial sheath in.
Radial sheath.
Yeah, so he wants to go pee-pee. So at this stage, you're gonna have to come on like this. Again, you know, you can ask me why we didn't do a Foley. I think we don't normally do it, and I don't think we should do it in this case. You know, I
100% agree.
think Foleys are causing infections.
Absolutely.
So at this stage, we're just working here, trying to get this done.
yeah, I'll give
Tell.
it. Just tell him to go pee pee. We'll clean it later.
So in case this stent doesn't cross in the second attempt, what is your plan for as a bailout?
Yeah, they're just changing my piece. I think we're gonna have to balloon with a bigger balloon.
Yeah.
Okay.
We're gonna have to put balloon with a bigger balloon.
You want a 7-0? I know what
Yeah?
a 7-0 chocolate.
Well, the pain is because he has to go pee-pee. All right, so now we're going to go with a step. Let's take a picture from. Give me a 6.0 balloon, guys. Give me a regular 6.0 high-pressure balloon Dorado.
60 is fine. Maybe 7, and then we dial it.
Okay, relax.
I think the lesion more more distal in the common external is what was the limiting factor.
Exactly. Yeah.
So
Let's take a picture then. Tell me which lesion you're talking about.
right around 25.
I think it's between 20 and 25.
Yeah, exactly.
Exactly where the stent was stopped moving.
Right at the arch.
I see.
Do you want another extension?
Is it a 6.0 balloon, guys?
Yeah.
So we have a question
And
from
then
the
get out
audience.
7 already, don't open it.
Would be an orbital atherectomy be a choice instead of IVL?
Absolutely not. For in our hands, I think that orbital atherectomy is not meant to be done in the iliacs at this stage. So I think no, definitely not.
I think it's just that.
No, it's not that. It's that.
Yeah.
So let's go up here.
Yeah, it's just a bias of the.
It's a bias of the calcium.
Okay.
So now we need to really be careful, guys. We're going up with the high pressure Dorado. Very slowly.
Mm-hmm. Four.
You need some more.
Contrast.
I don't know. It was diluted. Okay.
8.
It's 8.
Mm-hmm.
I can't even see it expand. Can you show me? Go to another view.
Coronary.
Is it expanded around 20?
There's still a waist.
No, it's expanded.
Yeah.
Go to 10 for me, just to make sure. Okay,
10.
okay, down. Let's see the pressure. Okay, let me go forward a little bit.
Yeah, exactly.
Let me get some more dye.
Hold the sheath right. Okay, go up
Okay.
again.
That's nice. So this is a Dorado 6.0 or 7.0,
8.
Dr. Krishnan?
6.
So 6.0
6.0.
at 9 atmospheres down. So now we're going to walk back and balloon around 20, as long as we don't lose pressure. Hold on. Where's my sheet?
Right
Okay. Okay, good. Come.
there. Somebody's holding the sheet?
Yeah, he's holding the sheet.
Oh, okay.
Yeah, I got it.
Go up one more time there.
Go up here.
Yeah.
Four. 6.
6, careful.
Okay.
8.
8.
We go to a different view. Oh, Ray, watch yourself. I'm coming. Oh, you can't. So she's stepping away. 4. Yeah, but I mean, I gotta go to a different view here. Yeah. Just want to see if it's expanded. Go to 10. Yes, it's
10.
expanded. Okay,
Actually
down.
looks very good expanded. Yeah, nice.
Now let me see if this balloon will cross now.
Hold on, let me fix one second. Go.
Uh-huh. Wow.
Mm.
Okay, go up again.
These are the big challenges
That's right.
of such an intervention.
2. 4.
Okay, down. You got pain?
No.
Down.
Yeah, I saw that. So at 16, you could see that waist right at 16.
Blood pressure is still very
Pressure's
good.
down.
Come on.
Look, it's coming back. Okay,
come
let's walk it out now. I think I'm gonna have to track the sheath across the lesion.
Yeah.
Uh-huh. Give me a dilator, guys.
Or
Walk it
maybe
out.
over this balloon.
No.
No.
Yeah, the other channel, biggest
you
channel is
grab a long
probably.
dial?
Okay,
Last thing
let's try it once without
to
anything.
strip your stent while trying to deliver from.
Come
a
on in,
25
come on in.
beacon.
So we're going to ask Dr. Rao to come in. Dr. Rao, as you know, has been scrubbed in so many of our cases.
7 pinch.
You want
This is a incredibly challenging case. Okay. No. Let's try with the stent first.
Yeah,
Okay.
that's what
We're going to try once with the stent, and if it doesn't go, then I'm going to get Dr. Rao's advice to decide on what to do. So again, listen, this is an example of collaboration and help, because obviously this is a very difficult situation for us, at this stage. And
Go.
we're there.
This is it.
Okay. Now
Wonderful.
walk it back.
But this is Dr. Krishnan. You showed it
Actually, this
nicely.
is good. This is good.
Easier to pull back.
Okay, ready for a picture? Okay. So Dr. Rao, we are dealing. Can we go backwards and show Dr. Rao what we're dealing with?
Good morning, Dr.
Good morning, Dr. Rao.
morning.
So sorry to bring you in on this case like
okay.
this, but really high risk. So go to the first shot. A really eccentric calcification.
Mm-hmm.
So we've got a critical limb ischemia. He's got a left main stent, low EF, no, turned down for surgery. He's got that. He's got common femoral issues. So we had a very difficult time crossing. Common femoral. So we came radially with a sheath, and there's a common femoral. So at the level of the profunda, and is a non-healing ulcer.
Okay.
So we came from below with SFA access, above from radial access, contralateral femoral access. We shockwave the common femoral. I'll show you what we got, and then we just balloon the iliac. And show Dr. Rao that picture. Yeah, no, after the shockwave.
Okay.
Keep going.
What size shockwave do you use?
6-0 there, because I didn't want to dissect.
So, Dr. Krishnan, we have another question from the audience regarding.
And that's after 4-0 balloon. Yep. 1 second, Sardar.
Sorry.
And then that's another shockwave there, 7-0 shockwave. Then 6-0 Dorado. And that's what we're at right now. So now I've got a 7-0-59 balloon across.
Okay.
I mean, VBX across. Yeah, no, this is the after shockwave. That's our common femoral now.
I see.
From no lumen to something.
Right.
But now we Dorado this. Now we're going to open this.
We did a
Can you show me that last iliac run again?
This one.
Yeah.
Yep.
I see.
So now I got a Dorado, I got a VBX across, I've got a landing zone, and now I'm going to balloon it.
Yeah, I mean.
So I've got a aortic occlusion balloon on the side. I've got a 8 French sheet. It's an esophageal XXL balloon on this side. I've got an aortic sheet, and we're just going to go up right now, as long as we're okay. Ready to inject from above?
Yeah.
Since we have a bunch of eyes here to help us. Inject,
Maybe
it's okay.
a little bit higher.
A bit
up.
higher
Actually,
up.
that's a very nice.
I like
actually,
it.
it's a good position.
What do you think?
Yeah, I think that looks good.
Yeah,
I mean, I
let's-
think.
yeah, right?
Yeah.
All right, let's go up. What's nominal? Okay, Liz, it's going to hurt him.
Go for it.
Oh, in his arm.
Okay.
Where, in the shoulder?
12 is normal.
Going up.
Is there an iliac?
Ready to go?
Up.
So here, Dr. Krishnan, you proved nicely how collaboration with other disciplines
going.
work immediately.
Go.
When needed,
Go.
our vascular surgeon colleagues are here to support us. Of course, we support them from our side as well. Very nice.
Yeah. Yeah,
Go.
no, I think this is of course, a very tough lesion,
Go.
high risk, and I think
Go slow.
kind of doing all
I
the
agree.
things that we can to be as safe as possible, which is,
Yeah.
using a covered stent, having a occlusion balloon available, having access on the other side in case we need to do.
So
Basic
remember the
stents or
7-0 ajitas, what is nominal?
12.
Go to 12. I would even
Now I have good
go to 14. Oh, 14, good. Good, excellent. So at least we have a decent expansion here. Might have to post-dilate. Down. Save that. Okay, so now, guys, what we're going to do is we're going to go up again to whatever you went up to. So now the issue is when you post-dilate these, they can go up to 11, right? How aggressive are you in this situation?
Yeah, I think in this situation, just because that calcium does go pretty close to the origin,
Right.
and I think our seal zone is, there's some seal, but it's not a lot.
Exactly.
I think if we create a 7 or even 9 millimeter lumen, that'll be more than enough.
Let's DSA from above.
And then you can be a little more aggressive about post-dilating the ends of the stent.
Exactly, right?
But I think, in this case, being a little less aggressive is probably a good idea just because of the amount of calcium there and, trying to avoid any risk of rupture or dissection.
Wow, that's a very nice lumen now.
I think at this stage, at least we have a lumen, right?
Yeah,
I
it's
think
a
you
lot
won't
better.
go with an 8 or a 9, you think? Or no? Proximally, we don't have a seal yet, though, Jet.
Yeah, so I think using maybe a larger balloon proximally,
8020,
just
8040?
proximal to that calcium, just to kind of flare it out a little bit, isn't a bad idea.
Okay, so you don't want to touch that calcium.
Not too much, because I think the stent, we can take another view, but I think the stent opened up pretty well.
Yeah.
So we know that's at least a 7.
8020, guys?
Yeah, I mean, I guess you're right. I mean, since we're not impinging on the osteum, what you could do is probably just do the right side, and at the end, inflate postal left, postal right, and then kiss it all the way top.
Yeah,
Okay, let's walk out the 8020.
right.
And there is still, unfortunately, not
Slow.
a
significant
significant improvement of the blood pressure on the SFA side, right?
Yeah. Because I
Oh
think
no,
that's-
this is not SFA. This is
Radio.
another side. What happened?
If there wants to come.
What?
Sardar, what?
I'm sorry, I didn't hear him.
Damien.
Okay.
Damien.
So
New
we're gonna.
8020.
Okay.
New
Okay.
8020.
Also,
Okay.
Also, the other thing is I think the stent looks pretty appropriately sized too. It looks like the iliac's on the smaller side to begin with, so I don't think it's really. I think it opened up pretty nicely
What do you
throughout.
have? Sure.
1 second.
Plenty of blood pressure.
You know, I don't think we're going to use a
a
9 or 10 all the way across.
Yeah. What do you have for Dorado?
Yep.
So Sardar, maybe you should come here and you can translate and also moderate from inside the room.
Okay.
He's getting in here.
Okay, because I think we're having a lot of trouble here with understanding him
Yeah.
because of the language.
Okay, I'm
that's
heading
fine.
out, yeah?
This is 8.
Thank you.
Aero what?
20.
Aero?
So it's an 8020.
I know. I'm going negative.
What did she do? She inflated it? Okay, that's okay.
It'll be good. I'll go. I'll stamp it down.
So just in these kind of lesions, ay. What is going on?
It's okay. Sardar is coming. His blood pressure is fine. He just has, I'm sure.
Where is the arm hurting?
And I think using shockwave in this area, even if we place the covered stent, is still a very good idea. Because a lot of times if you place a stent without doing that, you know, as we know, the stent's not really going to expand well. And then you have to be really more aggressive about dilating it, which could lead
Let's go
to
up here.
rupture and dissection and things like that. So
Yeah, so we're going to
think-
hang it a little in the aorta here, Ajit, to go ahead and do this. This way I avoid that calcium like you said.
yeah, this is an 8, you said?
80, yeah.
80.
Just go down, now push the wire up, Sriya.
Yep.
It's very important not to be on the soft part of the wire. Okay, good. Now go up.
10.
That's 10 atmospheres.
Yeah.
Okay, down. I mean, are we putting dye in this, or what are we putting in it?
It is.
I mean, let's walk back. Yes, sir. Yes, sir. Almost done. 5 minutes. 5 minutes. 5 minutes. I would go up distally.
1 second. 1 second.
Distally.
Yeah, 1 second. Let her follow with that.
Yeah, I think sometimes anesthesia is the way to go. You know, we try to do percutaneous, and because of his low EF, it's probably not the. No, you're in the wrong area. A little lower, you have to go. Bottom edge of the stent.
Okay.
Bottom edge of the stent.
But I think one of the at least more favorable parts about this lesion is there is a little bit of not severely
right there, right
calcified iliac proximally. So there is
Right.
a seal zone, which makes this a little lower risk, thankfully.
Okay.
4.
Because otherwise you have to
6.
consider like
8.
putting in a aorto bifurcated stent
Where's
graft
the pain?
potentially.
His hands are hurting? Okay. It's probably ischemic.
Yeah.
Huh? Ready.
Liz, can you give him a nitro paste on top of it?
Dr. Krishnan, what's your algorithm for putting in kissing iliac stents? If this
Nitro
went all the
paste
way
on
up to the origin?
You know, I think you would have to do that. In this case.
What's that?
I
I
think
can
you would
help.
have to do that. So we're going to take a DSA shot here.
You get the knife.
Ready? So we're going to see what it is, and then we're going to decide what we're going to do. Oh, that's beautiful.
That looks
Agreed? We're done here?
Yeah, I think so.
Okay, now, Ajit, I want to put the pressure on the SFA, and I want to see whether there's a pressure gradient across the SFA. So, come forward.
Coming forward. Hold on. Yes.
Okay. So we still have a tremendous gradient.
So this is to check the common lesion, right?
The common lesion.
Relax,
Yeah.
relax.
So now the question is, what should we do with the common lesion? Do we want to balloon him with a bigger balloon, like a 7.0 balloon, a 7.0 DCB maybe?
Remind me, what was the size of the shockwave? 6?
A 6.
خلاص خلاص عمو
So maybe a 7.0 60 DCB?
This is after a 6.0 shockwave.
Yeah, I mean, this is a tough lesion just because it's right at the bifurcation, and it's super calcified, as we know. So I don't think atherectomy is a good option.
Right.
I mean, we could try a DCB, but if the shockwave didn't do much, I'm not sure it's going to open up.
What about what else?
I want to make sure.
I think we're kind of limited with options, right? I think the only thing we can try is a DCB. I don't
Give
think
us
it's
a
a good
7.0 impact DCB 60.
Yeah, this wouldn't be a good place to stent for.
I mean, listen, he's end stage. He's not gonna. The problem is you may need cardiac cats in the future.
Mm-hmm.
So therefore, at some point, he may need to be stenting.
Yeah. It sounds like he's not a surgical candidate, but of course the other option to consider in other cases is femoral endarterectomy.
Right. I mean, we talked
What's
about
the
that.
fat on
We've
it?
spoken to him
What's
and the
the
family
fat?
about it. The issue here is that he's just not going to can't tolerate anything in
Right.
terms of his heart.
Right.
So the only question is,
Can you-
what is
can
the
we put
negativity
nitroglycerin?
about stenting? Why can't we put there is stent data available. We know it's not the best, but in this type of end stage case, why not just stent it?
I just worry that the stent won't open up, and then we've kind of lost all our options. And then I think, we already discussed the reasons not to do open, but obviously that should be thoroughly discussed for every case because, if there's a good surgical option, if
We got a balloon
patient
to
can tolerate it.
Yeah. So Ajit, how would you deal with the SFA hole now? That's my question. I mean, do I put
Is it relatively healthy there?
No.
I'm going to move the table, guys.
And I guess the other question is it calcified?
It is very calcified.
Hold on, let me get test from
In
the
this
top.
setting, I guess what I've been trained with, I've tried using the Minx
Come
under
back.
Yeah, your
fluoroscopy.
sheet has to come
So I
back
see
just
the
a touch
balloon
as well.
come back all the way to the, where the puncture site
That's good.
is. And then I think,
Take a picture.
Yeah.
the Minx is pretty atraumatic, so it's less likely to cause any injury to the vessel like a perclose. So,
Perfect. Go up.
so as long as you do the Minx under fluoroscopy, I think that's something I would try versus
What about an angioceal?
manual pressure. I think angioceal is another option.
Well, to me, the idea
not-
here, the idea, it's not ideal, but I could go up and over, but I don't want to put a sheet through the stent. The radial sheet looks like it has to come out because it looks like he's getting hand ischemia.
Mm-hmm.
So I was going to balloon tamponade with the radial sheet, but the issue here is what are the options? Because this is another part of what we need to do here. Okay.
Yeah, I think trying an angioceal, since we have up and over access, so we can shoot afterwards, is we can always fix it if we need to. Is not a bad
Right.
idea.
6.
Or a Minx. I wouldn't use a
Go to
perclose just because of all the calcium
Yeah, that's
proximally and
Just go to 10.
at the site of it. And manual pressure is what size sheath is it?
7
I see.
to do the
Yeah.
perclose.
So manual pressure might be a little higher risk just because it's below the femoral head. So
Yeah, there's nowhere to compress, and I
Yeah.
think our idea was to go from above with the radial balloon, but now it looks like the radial sheath has to come out.
yeah.
So if the radial sheath comes out, gives him a little bit of less pain in the arm, he'll calm down. The idea is if you look above, we definitely can go up and over with some trepidation across that iliac with a Cook sheath, and if we had to balloon, we could balloon. It's not something that's ideal for me,
Right.
but I think if we had to do it, we do it.
Yeah.
I mean, the balloon expanded well, so hopefully, there will be some recoil, but hopefully it'll give you enough luminal gain that your pressure should probably improve on the left side, and then
Yeah.
hopefully treat the disease.
And Dr.
the outflow.
Sardar, thank you so much for coming here.
problem.
Thank you so much. I mean, this is very, the communication issues were very big, but now we're really dealing with the very important part of the procedures.
Yeah.
How do we deal with the common femoral? I mean, the SFA. That's the idea. The other idea is to leave this balloon up, pull the sheath, and just hold pressure. But then when you pull the balloon out, it'll bleed again.
Extravascular.
Extravascular. I like angioceal here.
Yeah. I think angioceal is the best option,
ACT, Lizzie? Yeah. Okay.
especially with up and over access.
No.
Upper close is too
The other
deep
option
Extra.
in general is obviously we could
too
just do a
deep.
cut down and put a stitch in
and
it. but
calcified rays.
He's not going to tolerate that well,
no,
so
no,
that's
no.
not a good option
Yeah.
here.
I mean, it limits us like crazy. I mean, the problem here is that everything was against us in this case. He's not a surgical candidate.
Yeah.
we had everything going against us. And the idea here is, what do we do here?
Yeah.
So, I thought, okay, this is probably the best way to approach it. SFA, me and Sardar talked about it yesterday with Vishal and Shreya. We thought, okay, we initially wanted to avoid radial access, but it looks like I'm glad we have it now. At least we can see what we're doing.
What did you sing him, Sardar? Jingle bells?
For vascular closure?
I'm saying he's so quiet. What did you sing to him?
One more minute. So in these kind of
Nice
cases, would you
sedation.
have approached it? I mean, say this guy's not a surgeon, he's not. But say, it's in your hands now in the OR. What would you have done? I mean, could you have done this on the local in such a non-cooperative patient? No, right?
It would be very, very high risk.
Yeah.
And you need someone to be cooperative because you can definitely do a cut down under a local and minimal sedation, but you need a cooperative patient for that.
Yeah, no question.
Otherwise, yeah. So I think I would do the same thing that we're doing now is try the DCB afters.
Yeah, I mean, I'm just hoping that we get pressure gradient is gone.
Yeah.
And then if the pressure gradient is gone, I mean, it was almost zero before, so
Right.
at least we're getting something. If we get a pressure of 140, 160, I think we're done.
Plus, we're not treating like claudication, we're
No,
treating
no, this guy is
just
a wound,
CLI.
yeah.
So like we only need this to stay really open just until he heals
Okay,
his
down.
wound.
All
So
right.
you'll probably do a cut down first, treat the iliacs on your way out, do a endarterectomy with patch profundoplasty?
If he was a surgical candidate, yeah, that would probably be how I
The
would do
ideal.
this.
Well, one of the audience did ask us about that. So now,
Yeah, we had a similar case like this, I think, where we did a
خلاص سوا
femoral
الحمد لله
endarterectomy,
كله مشي
a
الحال
hybrid
مشي الحال
approach and an iliac stent. But I think that's why the shockwave is really a game changer, because these calcified lesions, up until now, we really didn't have any good treatments, because they don't really respond well to balloon angioplasty.
no.
Stenting, the stents don't expand well. So these are, I think shockwave definitely helps in these situations.
Yep.
All right, let's see the pressure.
Okay.
Still
It's
there.
120.
That's zero.
From 0 to 120. Ready to inject, ladies and gentlemen? No, through here. Through here.
Yeah. I have
Okay,
it.
ready?
Hold on. Yes.
It's actually better than 120. It's 130 now. Huge improvement. Oh, much better. Yeah, let's do it from above now. Ready? Okay, senor, no mueva.
Question is,
Ready?
there has to be a lesion somewhere? Inject.
Oh,
I
yeah.
think that lesion right there, because we still have
You
a
want to just
gradient.
stent that one?
That's still giving us some gradient, which shouldn't. I think the only thing that's is the eccentricity of that lesion right there probably is contributing to our. You want to zero both? I can zero both pressures, but this looks pretty much fixed.
Yeah, the distal
The
lesion
distal part looks
looks
fixed. I think
great.
that's what's giving us the pressure gradient. Zero for me, both.
So what do we do?
You could take another angle, just
1 second. Zero for me, please. Because there's still a significant gradient between the two sheets, which.
But it's right at the common femoral head.
Okay, good. Sorry. Yeah. Yep.
All right, let's see if the gradient is there. Give me a straight catheter. Give me a straight vert tip.
He wants to go PP.
PP. Okay, go.
the other thing to consider in these kinds of cases, I don't think we needed it for this one, but is putting a buddy wire into the profunda if you're really worried about it,
That's a great point.
especially if you're going to stent or something and you just want to have access, don't want to lose access to it. It's another thing to consider.
The rail. So we're just going to do a pullback with a straight catheter from the aorta. Show me above now. Okay, good. Wire out. Attached to that one.
The manifold?
That one. Manifold. Manifold.
Oh, manifold is attached.
No, you can do this.
That's what I was thinking.
Yeah, hold on.
The other thing I'll mention about these lesions is
We're going to
I
need
don't
another
think you should,
superport fell down.
necessarily have the expectation to leave with a perfect picture. Obviously, you want luminal gain and you want it to, clear all the stenoses, but because they're so calcified and so diseased, you're not going to end up with a perfectly straight tube. In these cases, that's perfectly fine because if I think you're over aggressive in these lesions, you can just cause more trouble than good.
Zero both, gang?
Oh, there's only one.
Yeah? Zero both?
Okay.
Okay, good.
Okay.
Okay. So there's a gradient even in the aorta. So I guess right above this, there must be some sort of stenosis. So it's what? It's actually 40 millimeters right here, right? 180, 218, right? 220.
I think
Yeah.
our goal is to mainly see if there's a
Exactly.
gradient in the iliac. So we just
Exactly.
concentrate on the blue one.
No gradient here. No gradient here. No gradient here. No gradient here. No gradient
Sorry.
here. No
That's all
gradient here. I think we're done. I mean, you're going to have a little gradient into the SFA
Which is
because of
fine, which is
normal
acceptable.
steel, but I think we're okay. What do you think? Stop, right?
Yeah, I think.
All right, let's get a wire in this, and then we'll just put a wire up. And then what we'll do is now we'll deal with the closure.
The right side first.
No, the right side is manual. Left side is the issue.
Oh.
Slowly, because he has a lesion there. Okay, my senor, okay. Nice. Nice. Okay, good. Okay, walk this out. All right, so now we got to see. You want me to go up and over a jit, or you want to just, there's a Lunderquist wire here now on the other side.
Yeah,
for
as
the-
long as you have a stiff wire up and over, it would be nice to
All
take
right.
a shot afterwards. So.
All right, guys, so give me now give me a UF catheter and a soft glide. No te mueva.
Got it.
UF and a soft glide, guys.
So now you want to go up and over. And
Well, I just want to, because if we can, we decided we're going to close this with a angioseal, right?
That's the plan.
So for that route, because I know we got to take that sheath out. If I get this up and over, I'll tell Ray to pull that sheath out with Shreya.
Yeah.
And put a hemoband, and then we can deal with this now, all of us together. Okay. Okay, Lunderquist wire out. Okay, wonderful. There is something going on there.
I mean, it's,
Hey,
I'm
mag
sure
up
there's
here?
a lot of calcification.
Okay.
Yeah. Yeah, we're just almost trying to get it out. Yeah. Nice.
Am I in the vessel?
Mm.
Yeah, it looks like it's looped in. You should be in the vessel.
Okay, let's see if this tracks now. Okay, very good. Okay. So now we can do an angioseal here,
Oh, you want?
right?
Yeah, but how do you want to tamponade it from inside? We're going to put a sheet up.
We're not. We're just going to do angioseal.
Oh, you don't want to do any internal?
Oh, you want to have a 5 French up and over just in case? Yeah, okay.
I mean,
Give us a 5 French supercore. I mean, a 5 French up and over sheath and a supercore wire.
yeah, you can. The balloon will hopefully track over.
Yeah.
We just put a wire down, just in case if I have to get a hemostasis, then I can do a say 5 French, 6 French, go up and over, and then do it. You can do it without the sheet. You just put a wire down. I just want to make sure there's something across it.
Okay.
But there's, if balloon tamponade could be plan B.
Okay,
and
give me
then-
a supercore wire then.
Yeah, exactly.
Inject, come forward.
Yes. So yeah.
And then the other option, just to discuss, is the last kind of a bailout option is just place a covered stent if all else
Yep.
fails.
Exactly.
Careful, Ray.
Here.
The roadmap.
Oh, this is Lunderquist. Sorry.
Okay.
All right, let's do the supercore. This is this. Can you give me another supercore? Damien, supercore. Yep, this one is on the left side.
Okay, Ray. Once his wire goes down, Shreya, you can go over there and take out that sheet.
Okay.
Hold on.
We have it.
Yeah, put some. Nice. I'm gonna take you off road map.
So again, everybody at home, it shows that this
watch
is
this
wide
out.
open.
Ray,
That's
watch
fine.
this.
That's fine.
You good?
Yep. You want to put a sheet up and over now?
No, I just want to keep the wire.
Okay, the wire's in.
Just in case I have to
Okay.
put a sheet, I have access.
Okay,
I'll
ready?
just go up and over.
Okay. So let's let them take out the TR band first. Let's take out the sheet first. So Ajit, when you close these, any techniques that you can tell, because obviously surgically you've got a lot of knowledge
You're
in terms,
walking it
let me
out?
move this down for you.
You want me to walk it
Put
out?
a dilator in, ladies and gentlemen.
Yep.
You mean
Can you grab this?
just closing in general?
Yeah, closing SFAs and other things. You know, you obviously you've got a,
So,
a
yeah.
tremendous.
So I think some of it's just what I was kind of trained with. So for me,
it's
per
the gray
close
one.
and minx,
This one, no?
I've used angioseal a couple,
Oh, there's a 6.
less often. I would say per close, especially for like an SFA lesion or somewhere where I can't hold good pressure, or if it's like obviously a large sheath, per close is my preference. Of course, in this case and in general, if you have like a very calcified vessel, you don't want to use per
Okay.
close, especially on the interior wall. If it's very
clotted.
diseased, you don't want to do it because you're
Put a wire.
very high risk of injuring the vessel. So in those cases, I either just hold manual pressure if I can, or I try to use a minx. The reason that I like the minx is
any wire.
because I can see my balloon go all the way back to the puncture site, and then you can just deploy it under fluoroscopy. So I think it's pretty atraumatic, and it doesn't work. You know, it's not as secure as putting a stitch in, but it's not a bad option.
Okay, so as far as minx gets a bad reputation, right? They
Yeah.
say, oh, it's extravascular, all that stuff. I mean, would you be comfortable in this kind of like with the SFA without having anything else except this? You know what I'm saying? That's my question, because you know, as cardiologists, I mean, I guess sometimes you talk about minx like, oh my goodness, high risk lesion, would you use a minx? You know what I'm saying?
Yeah, I know. If the minx, I do think has a higher potential failure rate. So if
Right.
like I didn't have a ballot option, I wouldn't use the minx. So like in this case, if I knew it was going to bleed if the minx failed, I would do what we're doing now, which is have a sheath up and over, ready to place
So
a balloon or stent, or just
can you
cut
do a
down.
minx? Because I prefer a minx to an angioseal here. I'll put a 5 French sheath up and over, and we'll have it ready
How about
as
a
a bailout.
vascular, Ajit?
You know what I mean, right?
Yeah.
Don't you agree? I think a minx is a better choice.
The only thing is that for 7 French sheath, I find like the minx fails more frequently.
Okay.
So
That's why the vascular probably might work.
Yeah. Okay.
yeah,
Then-
Vascade is also another.
Yeah, so we can definitely do that. Now, for everybody at home, when we're pulling this sheath out, it's very important to hold negative on the radial because it will stretch. Okay, wires out. Okay, now just pull it with the wire forward. You want extra stiffness. So Ray, you need to get close to the skin.
Coaxial, yeah.
Get close to the skin and pull short pulls. Short
Very
pulls.
important.
Very short pulls.
Yeah, right.
So
Wet ones.
okay,
need
there's
dry
wet
gloves.
ones. Very short pulls. Okay, you got it. Are you doing
Yeah.
it? Very short pulls. Are we doing it? Okay,
Yeah.
good.
Just small bites.
Small bites. That's all you want to do. So I'm going to come off fluoro so nobody gets radiated. Every now and then I'll just check. You coming?
It's coming.
Good. Very small bites.
Can you give me a dry gauze?
Dry gauze.
Here, take a dry. What happened to my pressure? Hold on. We need to hook it to something.
One thing I will say especially for common femoral artery access, when you have a 7 French sheath or less,
Don't move.
never be afraid to hold manual pressure. Kind of learn that the hard way. If you have a diseased vessel, sometimes that's the safest option because your closure devices just don't work well and can cause injury to the vessel in those cases.
Almost out. Almost out.
Yeah. Is it all
Get
the
the
way out?
TR band.
Is it all the way out? Or
Almost gonna be
Oh,
out.
it's going to be out soon. So for the audience at home, now you see like the different accesses, different sites, everything looks sexy, but you really got to plan these cases properly and have the right assistance. I mean, I think, this kind of situation, obviously he's ischemic in his hand. He doesn't have a lima, so we were able to go across it, right? So now as Ray brings it out,
are you going to take
get
the
ready,
wire
you got to pull
out
the wire
too?
back now. You got to pull the wire
Yeah,
back.
wire.
Pull the wire more into the subclavian. No, I
Yeah,
can
it's
see
still
it.
there.
Come, keep coming.
Pull back. Pull back.
Okay,
Can
that's
you
fine.
show us the
That's fine.
sheet?
That's fine. Okay, I'm coming towards you, Shreya, so you can be
Yeah.
comfortable. Okay, good.
Let me go AP. I'm just going AP so nobody gets hurt. That's it.
Can you show us the sheet or where it is?
What?
It's
Okay,
okay.
no.
Don't worry. Even if it bleeds a little bit, it's fine. There's no clot. You have to probably let it bleed.
Oh, hey!
Slow, slow, slow.
Let's see, I didn't see.
Don't.
Okay.
That's a 90, so.
Okay.
We good?
It's stretching.
Remove the TR band.
No, remove the dilator.
Oh, give nitro to them. Yeah. I'll do that. Give me some nitro, please. No, I have it. Okay.
So we have some elongation of the sheet. So what we're going to do is we're going to inject nitro into the sheet. So now we're going to sedate him a little more.
Okay. All right, fine. But this is not a. Is this braided? Probably that's why.
It is braided.
Yeah, that's why it kind of elongated that. Yeah. One second.
Very good. Excellent. Don't push the wire in. You don't need the wire in.
Okay, let's see what the sheet is. 1 second. I'm going to move to it. Oh, his hand is all the way here. Where is my sheet?
It's all the way there. We're going to have to turn the
Can
table.
you float the table for me?
Oh, yeah. hold on.
Yeah, sure. Watch. Okay, Flora.
Okay, the sheet is all the way there, guys. See where it is?
Right at the.
Okay, so you got to pull from there. Put the dilator in, yeah.
Okay, I have the wire. Okay. It's right at the brachial ulnar. I mean, the brachial elbow.
Resistance.
Hold on. Yeah. Well, is there a kink in the sheet somewhere here?
Okay. Any suggestions?
Okay. Let's do slow button.
You want to get gloved to just to?
Yeah.
Is there any hematoma in the axillary?
Okay, hold on. Flora?
It's in the body. The nitro, the pressure's down.
Hold on.
So now
Okay,
what we're trying to do, you can see in the fluoro, the sheath is in the ulnar and it's tremendously, it's tremendously elongated. So now we're going to try to just slowly pull it out. Is it moving?
Yeah. It's spasm more than anything else.
Yeah.
Yeah, that's why it's.
It's not moving?
Give me a. Can I get a
You wanna shoot
nitro
an angio,
paste
see
as
what's
well?
happening?
Or give some
You
more
want to
nitro.
shoot an angio? We can shoot an angio.
No, give me a nitro.
I don't think anything is happening, but walk the dilator out, right?
Yeah, give her Rapamil as well. Okay, hold on.
Because it's totally spasmed down.
No, but the dilator is never in the. It's in the sheath. It should be in the sheath. Oh, it's probably the artery spasm.
Yeah, the artery is totally spasmed, but
And give me a nitro paste.
we can inject through the side
Yeah,
of the dilator.
Oh, okay.
Give me a nitro paste. Give it. Open.
This is Rapamil? Okay.
I'll scrub it again.
Okay.
You want to inject through the dilator?
Put it on the elbow.
Oh, that's not.
See, I moved.
Or we'll lose the wire.
Put it right there.
Oh, yeah.
Put it.
Probably. Is the wire going in and out easy?
Easy.
It's probably still better just to leave it in there, just in case the sheath collapses.
Mm-hmm.
Okay. Give me more nitro paste.
Here's Verapamil if you want.
I can.
I take a feel.
It's okay. Hold on.
See here? Keep in the wire.
Okay.
Well, watch the sheet. Watch his
Hold on. I have
hands.
to, my hands are.
Mhm.
I did. I just put like 3
Take a
squirts
feel
of
over
this
this. Can you
on
hold
the-
this?
That's exactly what I did. Now, that's the next thing. But we injected through the sheet. We have still have.
Can I take a feel?
We should absorb with the.
It's coming.
It's coming.
Yeah,
It's coming, right?
that's something. The nitro paste. Yeah, it's now coming.
Is the dilator going in and out now?
Nope.
Are you okay if I just pull it out
Yeah,
over
just
wire?
take it.
Yeah.
Can you just, Flora, I just want to make sure I'm
It
not.
is Flores on.
Let me
it's
know
running
if you
out.
need to re-advance wire.
No, wire's great.
You want to put the
Watch
TR
this,
band
I'm
over
gonna
it?
move it back a
I think
little.
it'll be okay.
It's okay, TR band, we can figure it out. Don't worry about it. We can just hold pressure for 2 seconds just to make sure the sheet comes out.
Okay.
Okay, that's,
But hold on, don't put the TR band yet. Oh, you're good? Okay, good.
yeah, just don't inflate it though.
Yeah, don't put pressure on it.
Yep, you're almost there.
Yeah, that's fine. Okay.
Dr. Raman Sharma's here
Okay.
for us.
All right, inflate the TR
Raman.
band.
Crazy. They're just going totally into spasm.
We can technically pull the wire out as well, right?
Okay, wire can come out whenever you're ready.
Yeah. Is there any utility in taking a picture? Is there a pulse here? I just want to see proximate. Yeah, I think it's okay. I'm going to pull the
Yeah,
wire.
it's 98% O2 set.
Okay, no, I'm pulling wire.
Okay, wire's out. Okay. So again, for our audience at home, as you saw what happened,
Nitro paste.
lots of issues going on. Now I'm going to ask Sriya to examine the arm and the axilla to make sure everything is okay. Blood pressure is down. He's no longer in pain. So now we're going to deal with this now with our pressure being really, really low, which I don't understand why, but that's okay.
I'll give you another.
Lots of sedation, nitro, verapamil.
I gave like
All right,
nitro paste. Like
so let's do angioseal. You want to get a 5 French up and over or what?
I think it should be for visualization.
Yeah, in case you fail.
Well, then we have the wire across. We can quickly put the sheet over it
Okay.
and then just balloon it.
Okay. All right, let's go. Let's get the angioseal for Dr. Kapoor or Ajit or whoever's doing. Oh, we got a good pressure. Ajit, why don't you help with the or Kapoor?
I don't.
Actually, let
I don't use it that often,
Vishal, you can do it.
All right, let's go.
All right, let's go angioseal. So a tremendous case so far. You know, we've been able to. Yes, we've been able to.
I'm a big proponent of fellow seal rather than angioseal.
8 French angioseal, right?
Yeah.
8 French angioseal. So again, just to review now, we've been able to open the common iliac, open the common femoral. Obviously, hopefully now we'll be able to get this hemostasis, and then we'll be done.
Yeah, I guess my only question is there a way for us to shoot after we deploy
Yes.
angioseal?
Yes.
Yeah, we have the wire up and over, so if we want, we can track any catheter over it and
Okay.
pretty much.
Yep.
Can I get a ChloraPrep?
ChloraPrep. So it's about 2 hours into the case, and now we've been able to dealt with a lot of stuff that you've seen that happens. I just want to talk a little bit about radial access. I know that the R2P has been all the rage, but in any sort of complex case, you have this spasm that you're dealing with, and this is very, very real spasm. So as you saw, Dr. Rao went over there and actually used, I'm sure, a little bit of force to try to move that thing, right? You probably pulled pretty hard, right? Yeah.
Graceful force.
Yeah, graceful force, absolutely. Not really brutal, but
But I think the nitro
Not a
definitely.
surgical force. It's a real.
not orthopedic force, right?
But it wasn't as. I think the nitroglycerin definitely helped a little bit because it just.
We put the paste on it. That's
Yeah.
what we do. Put like 3.
All right, ready for angioseal? And also Dr. Sardar's idea of putting the what is it called, the warm blankets. I think that helped a lot as well. You know, trying to get that clean and get the artery warmed up. And you could see the patient is now. Is he comfortable, Sardar? How is he? I mean, in terms
He's sleeping.
Yeah, but I don't know. He looks awake now. See how he's doing, and blood pressure has been slowly came down to 124. Hopefully nothing major. We'll take a
we
final
gave a
picture
lot.
of everything. And the axilla is good and everything?
Okay.
Okay. Okay, good. Okay.
Hold on. Okay.
Okay, good. Okay, now let me come out for you, Vishal. You be comfortable.
Yeah.
Okay? Okay, there you go.
There's good flow. Hold on. Yeah, that's better. One marker back
There's nothing there.
and one marker in.
Okay, that's good. Okay. Oh, you guys took the wire out first. That's interesting. So now you can see he's just going to deploy an angioseal. Again, I want to tell everybody at home, off-label use of the angioseal, not meant to be done like this, right? So it's an off-label use of the angioseal, right? You know, so obviously
You see
there's
that
an
marker right
off-label
there?
situation. Okay, okay. Okay, you're good. Get us a Vertip catheter on this, please.
Don't move, don't move.
All right. All right, got it.
Okay, look at Vishal. Let me just come up and over now. Again, you have a fresh stent, so please be careful as we go up and over this really having issues here. There you go. Okay.
That would make it
Exactly.
even more challenging.
I think that's good. Wire out here. Okay, we're just going to take a picture through this. Pull back and set it up.
All right.
Okay.
All right. You're doing good, my friend. You're doing good.
Okay.
Nice and soft, actually. The whole
Good. I hope so. Okay, let's do a quick DSA. Okay, excellent. Hopefully, last picture here. Look at Vishal. I'm going to come toward you with a manifold. Careful.
Yeah. I'm
Oops.
going to get my fingers out at the end.
Okay, a little. Okay, ready, DSA?
Yeah.
Is that a bleed there?
No. I'm just showing you the mark.
Watch his
there.
hand. The profundo is gone, or what? Say
No.
minus?
No, go back. Go back. Yeah. No, everything is there.
Okay, perfect.
Mm-hmm.
All right, we're done. There's no issues at the site, right? Should we balloon it or anything?
No, I think.
No.
Looks good.
You okay with that, Ajit?
Yeah, looks good.
Okay, we're done. Okay, guys, beautiful. Okay, so let's see the pulses and we'll be all done. Well, thank you again, Dr. Rao. Appreciate it very much.
Of course, happy to help.
And from Sinai here, we're going to sign off. I think it was a great case of alternate access, a little bit of spasm at the site, but I think we'll be fine in terms of how this patient does. We've gotten rid of the two major lesions, and now we're going to go ahead and debride the wound and hopefully heal his wound. So again, we'll see you in July with the new group. I want to congratulate our two graduating fellows, Dr. Raman Sharma and Dr. Sri Avadani, who I'm glad Raman is in the room, and who are both graduating. Both of them are staying on at Mount Sinai, and I'm going to have great careers here. So welcome both of you, and congratulations, and thank you for the hard work. So see you all next academic year. Thank you. All right. Great.